Okay, picture this. You're called to the ICU for a post-op patient that just had a gastrectomy, right? Open scar, definitely some signs of pus, and suddenly, they are absolutely crashing. We're talking sudden, completely refractory hypoxemia. What's your very next move? Welcome back to Anesthesia Learners Academy. I'm super thrilled you're tuning in today because we are going to dive right into this clinical vignette and master the high-yield essentials of ARDS. Look, if you're prepping for your fellowship exams right now, this is the exact scenario you need to know cold. So let's get into it.
In this explainer, we're going to break down acute respiratory distress syndrome into a really structured, easy-to-digest clinical pathway. ARDS is this acute, diffuse inflammatory lung injury that frankly carries a massive mortality rate in severe cases. But don't sweat it. By the end of our time together today, you're going to have a rock-solid framework to confidently diagnose, understand, and manage the whole shebang.
Here's our roadmap for the explainer. We'll hit 4 main stops. First, diagnosis and classification. Second, etiology and pathophysiology. Third, lung protective ventilation. And finally, rescue therapies and care.
All right, Section 1, diagnosis and classification. Let's see how we actually pin down this diagnosis.
So you can't just walk up to a bed and guess a patient has ARDS, right? You've got to prove it. And we do that using the Berlin criteria. It's a non-negotiable checklist with 4 specific points you absolutely must hit. First up, the onset has to be acute. We're talking less than 7 days. Second, you need to see bilateral infiltrates on that chest x-ray. Third, and guys, this is a huge trap on exams. You can't just glance at the x-ray and assume the fluid isn't cardiogenic. You literally have to rule out cardiac pathology using an echo. You need proof this is non-cardiogenic edema. And fourth, you have to estimate the PF ratio. That's your arterial oxygen partial pressure divided by the fraction of inspired oxygen.
Now, take a look at the inclusion of both millimeters of mercury and kilopascals here. If you're sitting for international exams like MRCP or PLAB, having those kilopascal conversions locked in is an absolute must-know. And don't forget the classic exam trap. Grading severity here assumes the patient is already on a PEEP of at least 5. So mild ARDS is a PF ratio between 200 and 300 millimeters of mercury. Moderate drops down to 100 to 200. And severe ARDS? That's a ratio of less than 100, which means you are dealing with profound refractory hypoxemia.
Moving on to Section 2, etiology and pathophysiology.
The big question now is why? Why did our patient crash? Well, a classic board question tests your ability to distinguish between direct pulmonary hits and indirect systemic causes. Direct hits are exactly what they sound like: pneumonia, aspiration, lung contusions, or inhaling something toxic. But then you have indirect systemic causes. Think back to our post-op gastrectomy vignette for a second. That patient had a festering wound that progressed to sepsis, right? And boom, sepsis is the single most frequent trigger for ARDS overall. Other indirect culprits include things like pancreatitis, massive trauma, or severe burns.
So what's literally happening inside the lungs? Mechanistically, it starts with a physical break in the alveolar capillary membrane. It just ruptures. That break opens the floodgates, allowing protein-rich fluid to just ooze right into the alveoli. Naturally, this flooding completely blocks oxygen diffusion, which explains the brutal hypoxemia. But the real kicker? There's a critical loss of surfactant. Without that surfactant, those fluid-filled alveoli are basically guaranteed to snap shut and totally collapse at the end of every single expiration.
And if you don't get control of the underlying cause, say a highly resistant bug driving that sepsis, the disease marches forward on a very predictable timeline. It kicks off with the exudative phase, then morphs into a proliferative phase. And here's the scary part. If they haven't turned the corner after 21 days, they enter the fibrotic stage. That damage is permanent and irreversible, so catching it and managing it early is everything.
Okay, Section 3, lung protective ventilation strategies. Let's get into the mechanics of saving these lungs.
This right here is the absolute bread and butter of your ICU management. We're talking about the precise ventilator metrics you need to protect the baby lung, since the actual functional, compliant part of their lung is drastically shrunken down. Normally, you might run a vent at 8 to 10 milliliters per kilo. Not here. You must burn this number into your brain, 4 to 6 milliliters per kilo. Keep those tidal volumes low. And here's your ultimate board trap. That is based on predicted body weight, not actual body weight. If you use actual weight, you're going to cause severe volume trauma. Now, to make up for those tiny breaths and still wash out the CO2, you have to crank the respiratory rate, sometimes all the way up to 35 breaths per minute. Low volume, high rate. Now remember that loss of surfactant we just talked about, the alveoli snapping shut? That explains exactly why PEEP is absolutely crucial. Positive end-expiratory pressure acts like a constant artificial stent, holding those surfactant-depleted alveoli open at the end of every breath. You're aiming to keep this at or above 5 centimeters of water, always.
Here's another massive fellowship exam threshold you gotta know. Plateau pressure. You need to keep it strictly under 30 centimeters of water. To measure this on a sedated, paralyzed patient, you just hit that inspiratory pause button on the vent. It gives you the static pressure when there's no airflow, which basically tells you exactly how stiff that ARDS lung has become. Just remember, keep it under 30.
Right alongside that is driving pressure. Super simple calculation here. It's just your plateau pressure minus your PEEP. To minimize the cyclic stress and strain on those delicate lungs, you've got to keep your driving pressure tightly under 15 centimeters of water.
Now, I know it is incredibly tempting to look at a hypoxic patient, crank the vent to 100% oxygen, and just walk away. Please don't do it. Treat oxygen like a drug. High concentrations crank out toxic free radicals that actually cause more pulmonary toxicity. Sure, you might need to start at an FiO2 of 1.0 in an emergency, but your job is to aggressively titrate that down below 60% within 24 to 48 hours. What's the clinical target? Just keep that oxygen saturation right above 88%. That's it.
Beyond just spinning dials on the vent, there's a mantra you will hear every good intensivist repeat. Keep the patient dry. You want a net negative fluid balance. You cut back IV fluids, you concentrate your drips, you hit them with diuretics. Why? Because you absolutely have to stop those damaged, leaky capillaries from weeping even more fluid into the alveoli. Dry lungs are happy lungs.
Finally, Section 4, Rescue Therapies and ICU Care. Let's look at what we do when standard strategies aren't cutting it. Sometimes, despite your perfect low tidal volumes and dialed-in PEEP, the hypoxemia stays dangerously refractory. When that happens, you have to act fast. Your immediate rescue move is prone positioning. Literally flipping the patient onto their stomach works wonders for VQ matching. The guidelines explicitly say you need to prone them for at least 16 hours a day to see real outcome benefits. Write that down, 16 hours is highly testable. Now, if proning fails, you need to start thinking about ECMO early, extracorporeal membrane oxygenation, to totally take over gas exchange while the lungs heal.
But hey, don't get so hyper-focused on the vent that you forget the big picture. The ventilator doesn't actually cure ARDS. It just buys you time. Your daily ICU checklist still matters. You've got to treat the root cause. Hit that post-op sepsis with aggressive antibiotics and source control. Plus, you need your standard DVT and stress ulcer prophylaxis, rigorous prevention of vent-associated pneumonia and pressure sores, and you've got to be constantly evaluating them for spontaneous breathing trials the second it's safe.
We've covered a ton of ground today, from the Berlin criteria all the way down to the rigid vent targets for the baby lung. But as you prep for your anesthesia fellowship exams and head onto the floor, I want to leave you with this thought. With ARDS protocols constantly evolving, which of these strict ventilatory metrics is going to be your strongest clinical anchor during your next ICU shift? Mastering these numbers isn't just a hurdle for passing your tests, it's having the exact knowledge you need right in your back pocket to step up and save a life when the monitor starts screaming. Thanks for joining me on this explainer. Keep crushing your studies, and I'll catch you in the next one.